Good morning. Can you hear me?
Hi, Isaac. Yes, we can hear you.
Okay. So can I begin, or you want me to wait a few minutes?
Can we just give another minute for everybody to get here?
Okay. It's open.
Morning. Good morning, everybody. Today we have Dr. Isaac Barnor from Red Cross Hospital presenting on congenital midline laryngeal lesions. You can start, Isaac.
Okay. Thank you very much. Good morning. So, as was introduced, I'm talking about congenital midline laryngeal lesions, but specifically, I'll be looking at webs and clefts. Sorry, my PowerPoint is not. Don't know what's happened. It's not moving. Okay. Yeah, so I'm Dr. Isaac Barnor. I'm from Ghana, West Africa. I work in a district hospital known as St. Peter's Hospital in the Ashanti region. Ashanti region, it's in the middle belt of Ghana. It's a forest, dense and forest-rich area. Unfortunately, with a population of 32 million in Ghana, we only have less than 100 ENT surgeons. So ENT practice in Ghana is still a very young discipline. I'm presently a pediatric ENT fellow at the Red Cross Memorial Hospital. So I begin with a case we saw last month in Red Cross Hospital. This is a case of an 18-year-old male term baby who was referred on account of a soft cry, intermittent noisy respiration, which they term as stridor, and breathlessness on feeding. On examination, this baby had no stridor at rest, was quite comfortable, saturating at 98% on room air. However, had mild subcostal recessions, had no cleft lip or palate, and was on nasogastric tube feeding. A flexible nasoendoscopy was done in the clinic and showed bilateral coronal stenosis. The child had a type 1 laryngeal cleft. Also had was also found to have an anterior glottic webbing that occupied more than 80% of the glottic space. And a genetics workup was done to rule out the George syndrome, which came back as negative. And then an echocardiogram was also done, which also showed normal findings. So this was the FNE. Pardon the quality, but I hope you'll be able to see. So the FNE was done and could see the web and then the cleft. So a flexible laryngotracheoscopy was done. Obviously, this we couldn't do a direct laryngobronchoscopy because of the small opening, and we didn't also want to disturb the airway so much. So we opted for a flexible laryngotracheoscopy, which actually showed this narrow laryngeal opening with this thick glottic web. So this procedure was done with a laryngeal mask airway, so can actually see the squashing of the arytenoids, which has splayed the cleft, so you're not really seeing it so much here. So plan was to secure the airway. So a tracheostomy was done by myself and Dr. Salimo with the LMA, because obviously we couldn't intubate this child. So we did a tracheostomy with the LMA, and the size 3.5 NEF tube was secured. Patient was then assessed by the speech and language therapist on feeding and swallowing. And then patient is now being prepared for an open airway, which is an anterior posterior cardiac split with a costal cartilage graft and a laryngeal to create a new anterior commissure. So I'll start with laryngeal webs. And a laryngeal web is an incomplete recanalization of the primitive larynx. Now, this recanalization occurs during the 8th to the 10th week of embryologic life. And these webs result from a disruption of autolysis of the laryngotracheal groove during the 10th week of embryogenesis. So the degree of webbing that a child will have will depend on the time at which this recanalization stopped. So if it stops early, then it's going to lead to a complete laryngeal atresia, as we find in children who undergo the exit procedures. It's a very rare laryngeal lesion, approximately just 5% of all the congenital laryngeal lesions, and was first reported by Fleischmann in 1882. Cohen, who is known or linked to laryngeal webs, gave an occurrence of 1 to 1,200 beds. That's when he worked on it. But some publications are giving 1 to 10,000 beds, but making it even more rare. This laryngeal webs follow similar embryologic mechanism as seen in the congenital subglottic stenosis, but this involves the glottic level. But as we will see later, it may extend to involve the subglottic space. So the main etiology, as has been found, is the Sprinzen or the DiGiorgio syndrome, or they're also known as the velocardiofacial syndrome, which is a microdeletion syndrome, 22q11. And then, but not all children with glottic webs have this syndrome, as we saw in my patient, because only about 65% of them will have the deletion syndrome. Now, this deletion syndrome has a wide range of anomalies. Some are even reporting about 185 different anomalies affecting most systems in the body. So this laryngeal webs are graded, and most of the symptoms are also linked to the grade of the laryngeal or the type of the laryngeal web. Now, this grading is done in terms of the length of the web, if there's any subglottic extension, the severity of the symptoms. And as I said, Cohen is the one who spearheaded this classification in 1985. So we use what we call the Cohen's classification. So all patients with laryngeal web will definitely present with some degree of dysphonia, ranging from mild hoarseness to complete aphonia. And the airway symptoms will definitely increase as the length of the web or the extension of the web also increases, with some of them actually requiring tracheostomies. So we'll look at the Cohen's classification. So we have types 1 to 4. So the type 1, as you can see, very thin anterior webs, occupying less than 35% of the glottic space and or the glottic length. And then normally they are usually asymptomatic, but some may present with mild hoarseness. The type 2 has very thin to moderately thick webs. Type 1, type 2 are usually more thick webs, but this involves about 35 to 50% of the glottic length. And then such children will present with weak husky cries with mild airway symptoms. And the type 3, so now the web is getting thicker and more fibrous. So type 3, they present with thick webs with the anterior, thick anterior webs with potential subglottic extension. So the 3 and 4 tend to have subglottic extension, but some type 3s in rare cases do not present with subglottic extensions. And this occupies about 50 to 75% of the glottic length. And such children will present with very weak voice with moderate airway symptoms. So the type 4, as we found in the case I presented, they present with a uniformly thick web, obviously with a subglottic extension, and it occupies about 75 to 90% of the glottic length. And they present with aphonia with severe airway symptoms that require tracheostomy, which was done on our patient. So how do we assess a child or a patient who presents with laryngeal webs. So as we saw from the symptoms, even from the history, you would be able to at least have something in mind. But the flexible nasal endoscopy, which is done in the clinic, can also give you an idea. And it also helps to also, apart from helping you with the diagnosis, can also help to assess the arytenoid mobility or any possible extralaryngeal size of airway obstruction, rule out other congenital laryngeal lesions like laryngeal clefts. But the gold standard for most of the congenital laryngeal lesions is the direct laryngotracheal bronchoscopy, expansion microlaryngoscopy, because this is the gold standard, because this will help you to assess precisely the subglottic extension of the web. It will also help us to assess the size of any residual subglottic lumen, and then palpate the web for the presence of a possible cartilaginous component. So DLTB, as you find us writing in our notes, is really indispensable when it comes to congenital laryngeal lesions. And some additional examinations that can be carried out include an echocardiography, which we did, genetic workup, and then a CT scan, sometimes in cases of estimating the length of the subglottic extension when an open airway is being anticipated. So in the management of laryngeal webs, they are managed according to the severity or according to the Cohen's classification. So we have different options for different types of webs. But the main objective for any laryngeal web repair is to restore an optimal airway, obviously, but then we also have to ensure good voice quality. And how do we ensure this good, ensure the voice quality is precise division of the web down the midline to the anterior commissure? Must ensure preservation of the vocal ligaments so that there's no damage to them. And then the edges that are excised should be mucosalized to develop a sharp angle at the anterior commissure with no adhesions or synecdoche. And then there must be adequate treatment of the associated subglottic component. So we'll look at the various management options available for us. So for the type 1 and 2, normally they are managed endoscopically. So type 1, in some cases, are not, if they are asymptomatic, are not even managed. I mean, we just leave them alone. But if they are causing some symptoms, as in worsening of upper respiratory tract infections, delayed treatment is preferred, especially at the preschool age. So the sectioning of the membranous web, as you can see, is sectioned, and then a flap is raised and then reflected on one homolateral vocal cord to prevent synecdoche. And this flap is then secured with either sutures or fibrin glue. The type 2, also a late repair is preferred. Why do we prefer late? Because the infant's larynx is small. I mean, by age 4 or preschool age, the larynx will be large enough. And then also the infant larynx cannot tolerate the silicone keel without a tracheostomy. So at age 4, where they are old enough, then management of the type 2 is actually preferred. So this is also mainly endoscopic, where there's endoscopic plates with a placement of a silicone keel, which is taken out after 4 weeks. But some centers just do a split and then with associated balloon laryngoplasty. So they will split the cleft and then do a balloon laryngoplasty, even for up to the type 3. So some centers are doing it and also reporting on it, but they tend to recur and then might need revision surgeries. So the type 3 may be repaired either endoscopically or open. Like I said, not all the type 3s are associated with subglottic extension. So those that are not associated with subglottic extensions can be repaired endoscopically. But if there's subglottic involvement, then an open airway approach should be also considered. So the timing is based on the airway symptoms. And then if a tracheostomy is required, then the repair is done usually during the first 2 years of life. And the type of surgery depends on the degree of the subglottic extension, for already said. And we normally do an anterior cricoid split because the type 3 normally involves anterior segment of the cricoid. So it involves anterior cricoid split with a costal cartilage graft interposition. and then a laryngeal stent is placed. Now, this stent is placed to help in the formation of the anterior commissure, and then this stent is removed after 3 to 4 weeks. To the type 4, as we found in our case, is usually, like I said, involves a subglottic extension, causes cartilaginous subglottic stenosis. And then it also leads to marked deformity of the subglottic space. So treatment is by open surgery or open airway. And then we do both an anterior and a posterior split to widen the subglottic space. And then with costal cartilage graft interpositions, and then a laryngeal stent is placed. So there's this publication by Ko and Rata. It's a very good one, which I would encourage all of us to have a look at. It actually gives a step-by-step approach about everything you need to know about managing glottic wedge, both congenital and acquired. What are some complications that we anticipate? So dysphonia, when there's damage to the ligaments, laryngeal atresia, which may require revision surgery, recurrent laryngeal nerve injury, bronchial aspirations, and almost all the complications associated with LTRs, that is laryngotracheal reconstruction, should be anticipated. Now, this paper also looks at the 12-year evaluation of open airways. So like I said, so for the types 3 and 4, they are managed with open airways. So this paper looked at the outcomes of the open airways, and they actually found that it helped them establish a patent airway with successful decannulation in all cases. I mean, for us, in open airway reconstruction, we also assess our success by the number of patients that you can successfully decannulate. So they found from their study, a 12-year evaluation, that they were able to decannulate all the cases of type 3, type 4 that they actually repaired with an open airway approach, with about 91% of them also having the quality of voice also improving. Now, some centers advocate the use of combined endoscopic and open airway. Now, the combined endoscopic and open airway to obtain a sharp anterior commissure and also to develop an adequate airway. So this has been found to give optimal voice and airway results. And this is also the approach that we also adopt in Red Cross Hospital, as has been also postulated by this publication. So I'll quickly show some videos. Because of time, I won't be able to show lots, so I just made short videos. So this is a laryngeal web repair that was done here. So as you can see, this was a combined approach. There's an open airway and then endoscopic. So this one shows the web being divided. Then after division of the web, so we've done the anterior split, or the laryngeal fissure is done. So we have to place the grafts for placement of graft or widening the subglottic space. And then we also have the posterior. So the posterior split is also, that's in the posterior plate is also excised for placement of the posterior graft. Then after the placement of all of these grafts, a stent is placed to allow for healing. As I said, for lack of time, I can't be able to show everything, but this is basically what we do. Okay, so let's quickly move into the laryngeal clefts. So the clefts, what is a cleft? A cleft is also is known as a crinocaudal slit defect. Now, this is a defect in the party wall. Now, this party wall is a wall or the division between the airway and then the esophagus. So that's between the that's the pharynx and then the esophagus. So between the laryngotracheal airway and the upper digestive tract, so we're looking at the pharynx and the esophagus. This is also another rare congenital laryngeal anomaly. Reports of about 0.5 to 1.5% of all congenital laryngeal lesions, but this is now disputed because some publications actually think that this is quite low because of referral bias, and then most, especially the type 1s, are not really reported because most of them tend to be asymptomatic. So recent studies by Parsons and Chen revealed a prevalence rate of about 6.2 to 7.6, which is quite higher than the reported 0.5 to 1.5. So taking into account all the minor cases, as I've said, that are frequently overlooked and undiagnosed, the actual figures are likely to be higher. It was first discovered by Richter in 1792, and is associated with a high prevalence of GI, GU, and cardiac anomalies as well. Now, when the cleft extends to involve the cervical or the thoracic segments of the esophagus, that is extending all the way down, then it is termed the laryngeal tracheoesophageal cleft. British LTOC and the American will go with the LTEC. So the majority of cases of laryngeal clefts are sporadic. I mean, only few families will present with multiple cases with a slight male predominance. These high prevalence rates are also associated with other anomalies such as tracheoesophageal fistula and tracheobronchomalicious and other esophageal atresia. So 4 main syndromes are associated with the formation of laryngeal clefts, which we'll be looking at in due course. And then in laryngeal clefts, they are also classified. They were classified, were looked at by scientists, 2 scientists called Benjamin and Inglis. So they classified it also into 4 based on the extent of the cleft and also severity of the symptoms and any therapeutic challenges, and then the prognosis, which we'll be looking at. So generally, there are these 4 classifications, type 1 to 4. So 1 and 2. So 1 is when it extends to the vocal cord level. 2 is when it extends beyond the vocal cord, but not entirely through the cricoid plate. 3 is when it extends to the cricoid plate, but is limited or confined to the cervical segment of the esophagus. And 4 is when it extends beyond. So this is like the general classification. But then we use the modified Benjamin Inglis, which breaks the type 3 and the type 4 into A and B. So the type 1 and 2 stay the same, but the type 3 is when the cleft goes through the entire cricoid plate. That's the type 3A. And then the type 3B is when it goes beyond the cricoid plate, but still within the cervical segment of the esophagus. The type 4 is when it goes into the thoracic segment. That's 4A. And then 4B is when it extends into one of the main bronchi. On the right, as you see here, this is, what do you call it? It's a suggested modification of the classification, but we don't use this. We still use the modified Benjamin Inglis. Now, these are the 4 syndromes associated with laryngeal clefts. So there's Opis-Phrase or the G syndrome. There's the Chad and the Vector, which we know about, and then the Pallister-Hall, which mainly involves CNS anomalies. So these are the 4 syndromes which we can later on take a look. So in the modified Benjamin Inglis classification, there's a type 0, actually, which is not really part, but some also classify a type 0, which shows a submucosal cleft. That is not part of what we deal with. But a type 1, as I've already defined, extends to the level of the vocal cord. Then there's the type 2, which extends beyond the vocal cord. And these shorter clefts have about a 14% mortality. That's about 16 to 25. That's between 16 and 25%. And the type 3, so the type 3 and 4 are the LTOCs. That's the laryngeal tracheoesophageal clefts because they extend way into the esophagus. And then, as I've already explained, the A and then the B. And then the type 4, also we have the A and the B. So you can see the B extending into the right main bronchus. But the type 4s are associated with higher mortalities, something about 50% mortality. Now, what are the symptoms of laryngeal clefts? Now, these clefts, the severity is directly related to the extent or the type of the cleft. I mean, obviously, the more extensive the cleft is, the more the complications such as the aspirations and things occur. So there's usually associated with a combination of feeding and respiratory difficulties. So the type 1s usually tend to be asymptomatic, but then most of the laryngeal clefts will present with hoarse cry, stridor, and coughing or choking during feeding. The types 2 and 3 will present with more frequent and more pronounced symptoms, and then aspiration and recurrent pneumonias. And the type 4 will also show signs of early respiratory distress, that's the coughing, choking, apnea, and cyanosis. As I said, these are associated with very high mortalities. How do you diagnose a child with a laryngeal cleft? History, in this case, unlike the laryngeal waves where your history and symptoms may even tell what you're dealing with, in laryngeal clefts, they are really non-specific because a type 2 and a type 3A or B may present with similar presentations, usually, which is what choking or stridor or worsening or breathlessness on feeding. So radiological studies and endoscopic investigations are really mandatory, but endoscopic is a mainstay of diagnosis. So transnasal flexible laryngoscopy via a face mask can be done, and this will actually help you in assessing things like the vocal cord function, if there's any associated laryngeal malacia or laryngotracheal malacia, if there are any signs of aspiration, we will be able to assess all that. And it also helps us to actually look at the dynamic airway obstruction, especially with the malicious. I mean, once we do the flexible scope, we are able to actually identify those very, very well. But as I kept saying, the DLTB is the gold standard, because with this, you can actually properly assess the extent of the cleft, that's the length of the cleft, and select the most appropriate repair technique. Other investigations that can be done include a chest X-ray to rule out any signs of chest signs of aspiration. There's also a modified barium swallow that can be done to assess the swallowing and also to rule out any reflux and then aspiration if possible. And then you can also do some systematic evaluation. That's the genetic tests, cardiac and renal ultrasound scans, spine radiographs, because of all the syndromes that we actually looked at, and abdominal CT scans. So how do we manage laryngeal clefts? Repair is independent on the length of the cleft. So in this case too, we also have endoscopic versus open surgical approaches. So, but before you do your surgeries, you must ensure that we actually stabilize the airway, because we know they are usually associated with lots of aspirations. So we must find a way to reduce the aspirations and clear the lung infections. And how do we do that? So stabilizing sometimes might require a tracheostomy. You have to place it, must put on BiPAP or CPAP. We reduce the aspirations through taking fees or the use of proton pump inhibitors. But here, when they have severe reflux, we opt for the nascent fundoplication with the percutaneous gastrostomy, which will actually clear out the lungs and dry the lungs out so that repair can be carried out. So we look at the endoscopic repair. So that is usually that can be done for the types 1 to 3, which are symptomatic. Most of the type 1s, which if they are asymptomatic, we don't really do anything about them. But the types 1 to 3, when they are symptomatic, then we attempt the endoscopic repair without any significant comorbidities. And it can be done with or without a tracheostomy. That generally under general anesthesia with spontaneous respiration, that is the TIVA. So I just give very like short and concise steps so that we can actually see. I'll show you some videos also. So the edges of the cleft are denuded or freshened either with a cold steel, coblation, or a laser. I mean, a cold steel can be used in centers where you may not have access to a laser or a coblation, but the only problem with them is that you are going to be faced with lots of bleeding, and you may also lose valuable tissue that you may need for the repair. So the edges are denuded, and then the mucosa is closed from the distal end to the level of the cuneiform cartilages. The first two sutures that are placed down there, that's at the apex of the clefts, are the most important to ensure that the cleft actually stays closed and there's no fistula formation. And we actually close it in 1 or 2 layers. And then the knots are placed on the pharyngeal esophageal side of the cleft, not into the tracheal side of the cleft. So as you can see, so the knots are placed on the pharyngeal esophageal side of the cleft and not on the, as you can see here. Yeah, not on the esophageal side. So after the procedure, patients are nursed in the ICU, but they must be fully extubated or decannulated. We don't like to have foreign bodies like ET tubes and cannulas and things in there, because they will be sitting on the wound and they increase the risk of superinfection and wound breakdown that may lead to residual fistula formation. Patient is then ventilated on high flow or CPAP, and then feeding is via the NG tube until speech and language therapist assesses the swallowing, and then we give the required medical support. So I have these also short videos to actually show how it's done. So this was a type 1 cleft, but it was symptomatic, so patient needed a repair. The supraglottis has been dilated with the Lindholm self-retaining force cord retractor. So that's as you're seeing, so it's widening it up. And then this is the coblator, is being used to denude the edges. And then after the edges have been denuded, suturing is done. So the edges are closed by suture. And then after the suturing, now in this patient had a bit of laryngomalacia. So after the closure of the cleft, it actually led to narrowing of the laryngeal inlet. So a supraglottoplasty is also done, which involves division of these area epiglottic folds. So they bilaterally to widen the glottic opening. So after the procedure, so we see the cleft is closed, and then these are the excised area epiglottic folds. So the open surgical repair, that's usually done for the type 3, especially the type 3B and then the 4 clefts. And also for like a type 2, where there are relapses after failed primary endoscopic repair. So this more, it is used more as a salvage surgery. So for this open surgical repair, we have the extrathoracic and the intrathoracic LTOC. So these require different approaches. So the extrathoracic is also the cervical, as I said, the type 3, because it's still limited to the cervical segment of the esophagus. And then the type 4 is the intrathoracic. So different approaches are employed. So for the extrathoracic, a laryngotracheal fissure incision is used. And for the intrathoracic, an anterior cervical thoracic approach is also done. For the open surgical repair, especially for the extrathoracic. So let's look first at the extrathoracic, I said. So this is an extrathoracic approach, yeah, where the incision is done through a laryngotracheal fissure. So the repair is done to the level of the posterior laryngeal commissure. First, a tracheostomy must be done, but a low one, and then the percutaneous gastrostomy is also placed. So the incision is made, and then a posterior costal cartilage graft is secured, because definitely, I mean, there is a defect in the posterior cricoid plate. So a graft must be placed in there. So the costal cartilage graft is used, and this is secured. And then after it is secured, the repair site is reinforced with either a tibial periosteum or a clavicular periosteum or pericordium from a strip graft. So this is interposed between the trachea and esophageal mucosal layers to give some strength and to prevent breakdown of the closure. As I indicated, no stenting is required, because once you place a stent, you are going to put pressure on the repair site. That may lead to ischemia, necrosis, and then breakdown, leading to fistula formation. The open surgical repair, that is for the intrathoracic segment. This one actually involves a multidisciplinary team. So we need a cardiothoracic surgeon, the GI surgeons must be involved, anesthetics, because they are going to use more of a thoracic, cervical thoracic approach. So, and it's also an emergency surgical repair. Now, why is it an emergency repair? Because obviously you cannot secure the airway by placing a tracheostomy, because the cleft is way down. So a tracheostomy is not going to help improve ventilation. And then even an ET tube placement is also going to be difficult, especially if it extends into one of the main bronchi. How are you going to ventilate the lung fills? So this is, and then there's also an increased risk of aspirations. So this is an emergency surgical repair, especially for if we want to ensure survival, as it carries a high mortality rate. So the repair of the party wall is also done the same way. Trachea is done first, and then the esophagus. The reconstruction is carried up out to the inferior body of the cricoid ring, and the full laryngeal fissure is done to repair the posterior segment where a graft is placed to close up the defect. And the stereothyroid muscle is slipped between the cervical portion of the trachea and the esophagus. Now, there are major issues encountered following laryngeal cleft repair. And the two main ones are swallowing dysfunction and tracheal malacia that leads to airway compromise. So the swallowing dysfunction was assessed in this paper, which actually showed, which was a 10-year retrospective study. And they used that to evaluate and describe the swallowing function in children after a laryngeal cleft repair. And they found that the swallowing dysfunction after the repair was multifactorial. And it arose from concomitant neurologic, anatomic, and other comorbidities that may contribute to either the pharyngeal or the oropharyngeal dysphagia. Now, these other two papers, publications, as the evaluation and management, and this literature review, are also very good publications that actually also show a step-by-step approach, like gives you everything you need to know about laryngeal clefts and the modern repair techniques. So in summary, I presented on clefts and webs. So these congenital clefts and webs are rare airway lesions, as we've seen. Actually, I'm here to actually look at the prevalence in Red Cross. We have to take a look at it. And it's usually associated with other anomalies. So genetic testing is really important. Grading is done in direct correlation with the extent of the lesions and the severity of the symptoms. And as I always emphasize, a direct laryngotracheal bronchoscopy is a gold standard in diagnosing and grading of lesions and planning of appropriate surgical management. And management could be combined endoscopic and open surgical approaches, but the combined approaches have been found to be favorable in both of these conditions. And patient selection is also important, and proper optimization ensures good surgical outcomes. Thank you very much. So if there are any contributions or questions?
Thank you, Isaac. That was a good presentation. We'll open the questioning up to the floor.
Just to say, I think that was an excellent presentation. You can give that presentation anywhere in the world. It was excellent. Could I just ask, if you don't have good neonatal ICU or anesthetic services, is it okay? At what age, or does the surgery become easier as a child becomes older?
Yes, the surgery will become easier. That will be especially for the type 1 or the type 2. Yes, definitely surgeries for airway lesions become easier when the children grow because the airway becomes larger, the length of the neck also becomes longer, and they become more resilient. So it's definitely better and with good outcomes when the children grow. But if it's a bad one, like a type 3B or a 4, where the child is aspirating and having lots of chest infections, then we cannot really wait for them to grow. But if we're able to control these infections, as we do in some of these cases where we put in a Nissen and a PEG, which controls the aspirations and keeps the lungs clear, it allows us to actually buy some time for the children to grow before the repair is done. But in centers where you don't have good surgical teams and a well-equipped ICU, it will be very difficult to perform some of these complex surgeries.
But it could be reasonable to do a tracheostomy in those kind of settings and to delay surgery until the child is older.
Can you repeat that, Prof? I didn't hear.
Yes, it would be reasonable in those kinds of settings to do a tracheostomy
yes.
And then delay surgery until the child is older so the surgery is simpler?
Definitely. But like I said, a tracheostomy can only be placed if it's actually going to help. That is, if it's, like I say again, in the the type 1 and 2, where the trachea can go beyond the defect. That is only when a tracheostomy can help. But in some of the cases, like the type 3Bs and 4, where you can't actually ventilate properly with a tracheostomy, to be difficult to do that. So for some of them, we can put in a trachea if they are having bad stridor, and then also do the control of the aspiration, as I already said.
Another question I was going to ask is with the clefts, how do you avoid getting into arytenoid fibrosis and problems with stridor subsequently?
Prof, I didn't hear the first part. Are they going to have what? Fibrosis?
Yeah, you're with the cleft repairs. How do you avoid getting into arytenoid fibrosis and scarring, causing stridor subsequently?
Yeah, so like any surgical technique, proper handling of the tissues are always important, and that is why we also close them up in layers. So they are closed in layers to actually prevent the fibrosis, and then there are some grafts, like I said, the periosteal grafts can also be interposed to also help increase the strength, so that it doesn't scar down so bad, and then it doesn't also collapse, to increase the stridor.
Okay, thank you.
Thank you, Prof.
Any other questions from the floor? I don't see any questions in the chat.
I just want to say, can I say something, Jaco?
Yes.
That was really good. That was a really, really good presentation. I think it's fantastic that you put those two pathologies together, because the decision-making is quite similar, but also a little bit different. I agree with all of your comments, all of them. The questions that Prof. Fagan asked, I agree with those. And I think that this is why, Johan, we advocate for having all primary centers across Africa and many developing world countries to start with the tracheostomy program. Because first you save someone's life by putting in the trachea, and then you develop the program to do more specialized things. So you're less dependent on ICU and less dependent on anesthesia. And a lot of the kids that come back for surgeries and, grade 1, stage 2, all of those, they have a trachea as backup. So we always say start with the trachea. It's best outcomes with the trachea, and for many people, we wait for the kids to grow, but we don't want to wait too long, because it has a delay in the development of their speech and language acquisition. So we tend to say by 5, they must have been repaired. Those are with the webs, because they need to integrate into society, need to go to school. And that's why our limit at Red Cross is 5. You can do it younger, but the larynx has to drop, and our baseline is 10 kgs when we start, and to make sure that if they need rescue, if they get sick, or if they have prolonged an ICU stay with a tube in, that there's an acceptable 30% reduction in the caliber of the lumen. So we always say 10 kgs, and that's standard of care as well. Just the last thing about the fibrosis is an excellent answer what Isaac had said, but also we used to cut the tissue away. Now with advancement in technology, we use coablation or laser. So you actually split the layers rather than cutting it away. So you end up with more tissue, and the stitches have to be quite precise so you don't go into any of the joint spaces. So you actually try not to get deeper than the mucosal surfaces, and having an interposition of a graft or the periosteum actually allows it to lie flat rather than come up into the interarytenoid space, because there's no muscle, there's no interarytenoid muscle. So we don't tend to see fibrosis. We tend to find that we make it bigger and have to reduce the space rather than making it too small. The 5 millimeters of distraction is really all we need. But yeah, thanks. Very, very nice talk.
Thank you, Prof.
I don't see any more questions in the chat. Thanks for your presentation, Isaac. That concludes the meeting, and we'll meet again next week, Wednesday.
Okay. Thank you, Jacob. Thank you for excellent moderation. Thank you everyone for coming. Have a nice day.